So in this mini ECG nugget, I'd like to talk to you about the QRS complex. The QRS complex represents ventricular depolarization. It follows the P wave after a PR interval, which is a pause allowing the ventricles to fill. And with the QRS complex, there are several things you need to look at. Is the QRS complex narrow? Is it broad? Is it tall? Is it short? Because all of that may represent changes that have clinical manifestations that require either further treatment or certainly further investigation. So the QRS complex represents activation of the ventricle. It's normally less than 3 small squares, which is 120 milliseconds, and I'd strongly encourage you to look at the automated readout at the top of the letter telling you what the QRS duration is, rather than trying to measure the squares with some magnifying glasses and a ruler. The QRS complex follows a P wave, and we look at the width and shape, figuring out really whether it's left bundle or right bundle branch block, and whether there's left ventricular hypertrophy, typically is what you're looking for in primary care. So in this ECG, I just want you to kind of get your eye in here and ask yourself the question, is this QRS narrow or broad? And clearly the QRS is narrow here, and if you look at the top where there's an automated readout, the QRS duration is calculated at 102 milliseconds, which is less than the 120 milliseconds to classify it as a broad QRS, so a narrow QRS. What I'm showing you now is a broad QRS. So here the QRS is probably around the 150, 160 millisecond mark, certainly more than three small squares. And this is an example of something called left bundle branch block. But there's a separate video that it makes sure that you can always tell the difference between left bundle and right bundle branch block. Here we've got someone whose QRS is on the borderline of being broad, but the key thing here is the voltage, how tall the QRS is. And if you look at the ECG tracing, the voltages across the chest leads from V1 to V6 are markedly elevated. And that's not the only abnormality on this ECG. So let's use our 10-step system to go through the findings. This is an ECG of someone with hypertension who has come for their annual assessment. They have the ECG taken, and we look at it. So we know the indication, we know the demographics. Let's say they're 60 years old. And what we see is that the rate is certainly they're not tachycardic. We don't have an automated readout, but looking at it, that looks at about between 60 and 70 beats a minute. The rhythm is regular. Every P wave is followed by a QRS. There's no irregularity. The axis is left axis deviation because the QRS in lead 1 points upwards, the QRS in lead 2 points downwards, so it's leaving each other. It's left axis deviation. Now the QRS complexes look borderline broad, so let's say it is broad. It's about 125 milliseconds. But what I clearly see is the voltages almost blend into each other. So if you look at V2 and V3 and V4 and V5, the voltages actually cross from one lead to the next. And this leads me to believe that this patient has left ventricular hypertrophy. The other thing that we're seeing, if you look at leads V5 and V6, is that you have some ST segment depression and T wave inversion. These are what we call strain. And to clinch the diagnosis of left ventricular hypertrophy, which is what this ECG shows, you need to have 2 criteria. You need to have the voltage criteria, which is basically how tall your QRS complexes are, and your strain criteria, which is typically in the lateral lead to demonstrate some repolarization changes, i.e. that there is ST segment depression and or T wave inversion. So this is a classic ECG for left ventricular hypertrophy. And the best there are many criteria around to label people as having left ventricular hypertrophy on their ECG, but the one that's most commonly used, and certainly the one I'd recommend for primary care, is the Sokolov-Leon criteria, where you look at the S wave depth, which is basically the downward deflection in lead V1, and you look at the tallest R wave in either lead V5 or V6, and you add them together by calculating how many large squares you see in the S wave in V1, how many large squares make up the R wave in either V5 or V6, and if it's more than 7 large squares, you meet the criteria for the voltage criteria for LVH. But to call it left LVH, you must ensure that there are the strain criteria, which are the lateral ST segment or T wave changes seen If you have someone who's got a very slim physique or muscular, they may well have increased voltages simply because of their physique, but if they don't have the strain criteria, you should not and cannot call it left ventricular hypertrophy. They may still potentially have LVH, but they don't actually meet the criteria for pathological LVH by the Sokolov-Lyon criteria. So let's frame this with a case. So this is a case of a 35-year-old asymptomatic patient having an insurance medical, has had a normal cardiovascular examination. By that I mean the blood pressure is normal, auscultation of her heart has revealed normal heart sounds, no murmurs. And the reason he's having this medical is he's about to get a promotion in his hedge fund, the youngest person to ever do so. As soon as he does that, he's off to buy himself a very nice sports car, and he just needs a form signed stating that this ECG is normal. So let's assume you're reviewing this ECG. He's asking you to sign the form. The question is, do you sign this form off on the basis of this ECG? So the first thing you do is you note that you know why you're doing the ECG, who you're doing it on. You're doing it on a slightly arrogant young person who is desperately keen to get you to pass them, and they're asymptomatic, but there is this family history of sudden cardiac death. And what you don't just do is look at the ECG and yell out normal or abnormal. You use a 10-step system. So first thing to do is, what's the rate? The rate's quite slow. We're looking at less than 60 beats a minute. What's the rhythm? The rhythm is regular. There is a P wave followed by a QRS. What's the axis? The axis is normal. In QRS, in lead 1, the QRS is pointing upwards, and lead 2, the QRS is pointing upwards. So that's a normal axis. You've got P waves, which look slightly bifid. PR interval's normal. The QRS is narrow. But what is clear here is that the QRSs are increased. The actual height is increased. So in the S wave in V1, if we count the number of squares, it's 1, 2, 3, 4. And let's just take the R wave in V5. It's 1, 2, 3, 4, 5, nearly 6. So that's 10 large squares, which is 50 millimeters. So you have voltage criteria for left ventricular hypertrophy here. The next question is, are there any strain criteria? Well, clearly there are. If you look at in fact, throughout the ECG, all T waves are inverted, but actually specifically in V5 and V6, there are inverted T waves. So you've got a 35-year-old asymptomatic patient with a normal blood pressure, no evidence of aortic stenosis clinically, who has unexplained left ventricular hypertrophy. So clearly the investigation that you need to perform next is an echocardiogram. And if you perform an echocardiogram, a diagnosis of hypertrophic cardiomyopathy can be made because this young person, despite having entirely normal blood pressures, will have evidence of left ventricular hypertrophy, typically in the pattern of an asymmetrical septal hypertrophy, where the septum is preferentially thicker than the other parts of the heart, and often may actually obstruct the outflow tract, causing turbulence, something called outflow tract obstruction. And the key criteria is that the thickness of the heart typically needs to be more than 15 millimeters. Now, this is a generalized rule. There are actually criteria. There are times when the echo may even look normal, but you have to perform a test called a cardiac MRI, which may show hypertrophy that the echo is not picked up. But that's a talk for another day. The key take-home message here is that you have LVH, which is unexplained, despite a patient being normotensive, with no evidence clinically of aortic stenosis. You've confirmed that on an echocardiogram, and the echocardiogram has shown you findings of that will be consistent with hypertrophic cardiomyopathy. So very quickly, in a nutshell, hypertrophic cardiomyopathy is a genetic heart muscle disease that affects 1 in 500 of the population. It's autosomal dominant, so any offspring from or any first-degree relatives from an index case or from a new diagnosis, their first-degree relatives have a 50% chance of having this condition. So here in this case, the 35-year-old chap who lost his elder brother suddenly, it was almost definitely due to hypertrophic cardiomyopathy, and certainly hypertrophic cardiomyopathy is regarded as the leading cause of sudden cardiac death in competitive sportsmen and sportswomen. And hence in the screening programs with ECGs are kind of widely been rolled out to try and capture these folk before they put themselves at risk from competitive sports. So what I'm showing you now is a routine ECG on a hypertensive patient. It actually shows the same changes. There's left ventricular hypertrophy and T-wave changes, but the diagnosis is different here. In this case, the patient is on 4 antihypertensives. They have a blood pressure of 180 over 100 in clinic, and an ECG done clearly shows LVH, an echocardiogram would show LVH as well. So it very much depends on the clinical picture as to how you interpret the ECG. The key common finding is LVH, but what's the cause of LVH? In the first case that I've shown you, it was due to a familial hypertrophic cardiomyopathy. In the second case, I'm showing you it's due to uncontrolled hypertension. And in my mind, anyone who is on 4 antihypertensives and still has uncontrolled hypertension, the first thing you've got to ask yourself is, are they taking their tablets? So compliance is something I would actually look at here very closely.